Everybody, we'll go ahead and get started. Welcome to the meeting number 6 of the Budget Review Subcommittee on Health and Family Services. And as a reminder, no remote attendance by members is permitted in the 25 interim session. All members must attend in person, be recorded present. The meeting materials are put online and made available for downloading. So at this time, we'll have the secretary call roll.
Senator Berg, Senator Titchener, Representative Duval.
Here.
Representative Fleming.
Present.
Representative Johnson.
Here.
Representative Raymer. Representative Wilner.
Here.
Representative Wilson. Here. Senator Mays Bledsoe. Present. Senator McDaniel. Senator Meredith. Present. Representative Bowling. Representative Bray. Representative Heverin. Representative Moser, Representative Petrie, Co-Chair Richardson. Here. Chair Williams.
Here. Okay, we do have a quorum, so we're constituted to do business today. Before we get started, I would like to recognize Representative Wilner to discuss something real quick.
Thank you, Mr. Chairman. So I represent House District 35, which is basically a horseshoe all around the Louisville International Airport. And there was a devastating tragedy yesterday where a UPS plane exploded. It has affected a lot of neighbors and neighborhoods. In my area and across the city of Louisville, we know that 9 are confirmed dead. 16 people still missing with those family members. Hard to imagine what they're going through, but for all of us in our community, it was a very sad and very heavy night, waking up today to a very heavy, sad, and honestly somewhat disorienting day. And so I appreciate the opportunity and to ask all of you to keep your thoughts with those affected directly and those who are, struggling with just the psychological impact of seeing what was in our skies last night. Also, the first responders were absolutely amazing. The level of training and expertise and cooperation across agencies was truly inspiring to see. For people looking for updates, I know the Louisville Emergency Management System on all of their social media, they're posting regular updates for folks who may need assistance. But thank you, Mr. Chairman, and I wonder if we might observe a moment of silence.
Yes, if we would, we all stand for a quick moment of silence. Thank you all. Our hearts and prayers really are going with those who are affected by it, and we hope the recovery goes quick and well. Next, we need to approve the minutes from the October 15th meeting. Do I have a motion to approve? A motion, a second? We have a second. All those approve, please vote aye. Aye. All those opposed, like sign. Thank you. Minutes are approved. For our first presentation this morning, we have Justin Derringer with Medicaid Services, Vicki Bourne, and Jeremy Thompson with the Kentucky Transportation Cabinet to give us an update and overview of the Medicaid Non-Emergency Medical Transportation Program. And that program is funded through Medicaid and administered by the Transportation Cabinet. Would you guys identify yourself for the record, and then, well, before that, let's, if you don't mind, we'll swear you in. Do you swear or affirm to tell the whole truth and nothing but the truth? Thank you all. So if you would please identify yourself for the record, and then members, if you would hold your questions till the end of the presentation. Thank you. Go ahead.
My name's Justin Derringer.
Let me make sure you turn the button on and pull that in close to you so we can hear it good.
Hi, my name's Justin Derringer. I'm the Director for the Division of Healthcare Policy in the Department for Medicaid Services.
I'm Vicki Bourne, the Executive Director, Office of Transportation Delivery in the Transportation Cabinet.
And I'm Jeremy Thompson, Regional Program Manager
in the Office of Transportation Delivery Transportation Cabinet.
All right, thank you. Before we start, we've had a brief conversation about this during Moab from another perspective, and we wanted to bring the people involved in delivering those services, the contracts, and all that to get a different perspective on it. I think this is a topic that a lot of people didn't know a lot about. So it's why we're just trying to bring the education to the forefront, and we want to understand how it works from your perspective. So if you would go ahead.
Absolutely, thank you. So non-emergency medical transportation is a federally mandated benefit under the Social Security Act. So that benefit mandates that any state that receives funding from CMS for Medicaid has to have a non-emergency medical transportation program. States must ensure that all Medicaid beneficiaries have access to transportation to Medicaid-covered services if no other options exist for them to get access to those services. The Kentucky Department for Medicaid Services contracts with the Kentucky Transportation Cabinet to manage the NEMT program under a risk-based capitated model. NEMT eligibility for members that are eligible for NEMT, they have to be a Kentucky Medicaid beneficiary. They have to be traveling to a Kentucky Medicaid covered service, something that's covered under Medicaid. It has to be to a provider who is a Medicaid enrolled provider. The service has to be medically necessary, so it can't be an election or elected service. It has to be something that's proven medically necessary. And the member cannot own a vehicle. They cannot have a vehicle in their name that's operable, and they cannot have access to other transportation means. Individuals excluded from NEMT services are individuals in the K-CHIP Phase 3 members and members that have QMB services, which are services that exclude them from that NEMT program. There are other members that are excluded due to other reasons, such as members that are in ACE programs, because we pay a capitated rate to those providers to cover all services. NEMT utilization, so for state fiscal year 24, over 3,155,000 trips, 25, 3,363,272 trips. 18.4% of those eligible used that service during that year. In October so far, we have 1,308,652 trips. 76% of Medicaid members have vehicles that are registered in their name, so they wouldn't be eligible for Medicaid unless those vehicles are inoperable, which they have to provide a mechanic statement saying that those vehicles are not operable, or they do not have a driver's license for some medical reason. They have to receive a doctor's note or something from the Transportation Cabinet saying that they don't have a license in their name. So 24% based on that have a registered, do not have a registered vehicle. But again, those 76% could still qualify if they produced one of those things. Transportation Cabinet has broken down as our contracted entity in 15 different service regions. And so those service regions are in this map, as you can see. And each service region is assigned a broker. The Kentucky Transportation Cabinet's responsibilities, each single broker has 15 regions through a request for proposal bid under KRS Chapter 45A. A broker is an intermediary who coordinates rides between the beneficiaries needing transportation and the transportation providers that give those rides. Kentucky Transportation Cabinet collects and submits monthly trip encounter data, auditing for errors prior to sending to the Department for Medicaid Services. The Cabinet reviews all broker required monthly reporting, conducts broker assessments, maintains and manages the member call center and the 1-800 complaint line for NEMT issues, complaints, and inquiries. They approve, issue official denials of transportation requests, and they attend and testify for NEMT issues as well. They also review all transportation provider subcontracts that their contracted entities subcontract to provide those rides. They set subcontractor reimbursement rates, conduct vehicle inspections and ensure provider and driver qualifications are met, conduct random rider surveys and phone surveys, and conduct the coordinated transportation advisory committee meetings in partnership with DMS and the Kentucky Education Labor Cabinet and Office of Vocational Rehabilitation. The Department for Medicaid Services does their own surveys as well to ensure customer satisfaction with our NEMT program. Broker responsibilities to verify beneficiary eligibility, access beneficiary transportation needs, educate beneficiaries about the NEMT services available to them, determine the appropriate mode of transportation, whether it would be a private vehicle, a bus, a taxi, contract with transportation providers, monitor vehicle maintenance, inspections, safety operations, ensure driver qualifications, training, alcohol and drug testing, track and respond all complaints, and provide courteous, safe, and timely service. The beneficiary or someone on their behalf contacts the broker through a toll-free line to schedule their trip. We require a 72-hour notice unless it's for urgent care. If there's something urgent that comes up, an example of that would be a pregnant individual that needed to go to the hospital. In that case, it would be, but it wasn't an emergency type situation where they wouldn't need an ambulance, but they need to be there. Then it's a 24-hour turnaround. We can get them there to some kind of urgent treatment if that's needed. Transportation is provided within the member's medical service area or the closest medical facility available. We monitor that very closely, making sure that if there's a closer provider, Medicaid provider, that they're linked to that closer Medicaid provider in order to save money. Our referrals are required to go beyond any service area that in order for travel in case someone can't find a provider in their area. Again, urgent care is provided. It's available 24/7, and well, this is 12 hours and not 24. I misspoke. Each broker has a reservation line that's available Monday through Friday, 8 to 4:30, and Saturday from 8 to 1. Transportation services are provided 6 a.m. to 8 p.m. Monday through Friday, and Saturday, 8 o'clock to 1 o'clock. Scheduling and transportation services are closed on a few holidays. We get a lot of NEMT service feedback and support. We post this number on our website. Transportation Cabinet has on their website, and it's listed on the majority of our information material that go out to providers and members in order to get the feedback we need to make sure that we're doing a good job. As you can see, it's a 1-800 number. They can call at any point. In state fiscal year 2024, there were only 9,000 denials, 25 only 7,000. So you can see the amount of rides versus the amount of denials is pretty big. Customer satisfaction, 97.6% in 23, 95.15% on our rider surveys in those 2 years. The NEMT contract is $360,640,960 for state fiscal year 25 and 26. Of that amount, we paid out in state fiscal year 25 $174,953,006. DMS pays on a per member per month capitated rate, and you can see those capitated rates on the right are per region. So that would be per member, eligible Medicaid member in that region. Those rates are decided by an actuarial service that we contract with. Those are verified, make sure they're actuarially sound. Once those, we pay based on the enrollment, the Medicaid enrollment for that month to the Transportation Cabinet. If it's less than the contracted amount, that's all they get. They only get that per month, per enrollment data. And that's the amount we draw down from the federal government is the exact amount we pay. So there's no leftover or excess funds. DMS develops and certifies the capitation rate through a contracted actuary, which is then approved by the Center for Medicare and Medicaid Services. So CMS has to approve that actuarial rate and those calculations before we're able to use them. Rates are based on historical claims. They go back and look at the utilization rates and actual trips in order to provide that actuarial rate. They're adjusted for future periods and made to consider changes in enrollment, cost per service, and utilization. For state fiscal year 2026, adjustments were applied to account for incurred but not reported claims, potential enrollment changes, coverage updates, reimbursement rates, and prospective trending. Adjustments are also made for non-benefit costs to account for the cost for brokers to administer the program and a percentage of risk margin. A single capitated rate is established for each individual region based on the makeup of the members and experience respective in that region. The rates are then paid to the EMT brokers during the fiscal year through a monthly payment process based on the assigned enrollment. The majority of our members that utilize Medicaid reimbursement, usually over 50%, in some years 8 out of 10 are usually adult day centers. They usually have the highest utilization rate for NEMT services, as well as members that are going to a rehabilitative type care like dialysis and those type things. That's all of our presentation right now. If y'all have any questions.
All right, thank you. I got one quick question before we get started with the others. So when you're determining the brokers and the contracts per, I guess, KRS 45, who sets those data parameters or the quality metrics that's associated with that? I'm assuming built in the contract that providers have to meet these different levels of service or quality. Do you guys get together and do that with anybody else, or how does that? Could you explain to me how that works?
Yes, it's kind of a collaborative effort between the Medicaid service, between Medicaid services, between the Transportation Cabinet and the Education Cabinet, our Labor and Education, OVR. And so we come together, we develop based on the statute, based on the regulation requirements, which are primarily including the majority of the RFP includes those requirements.
Okay.
And then collaboratively we come together through the selection committee and review those.
Okay. We have any questions from members? First one up is Senator Richardson. You're recognized.
Thank you, Mr. Chair. Just a question. This is something that sort of came on my radar through a webinar recently about Uber Health operating in about half the states where Medicaid is able to reimburse for this. Pretty high percentage success rate. I'm not entirely sure what success is measured at. Maybe getting the person from point A to point B is the success. I'm not sure, but has the cabinet looked into any services like that with sort of a national brand like Uber Health?
Yes, sir. We've done several studies within the last 4 or 5 years on different states, the different models that they use NEMT services. All of their and what we really looked at to truly measurement was the cost of that program, the cost of those services, and then the user surveys, which we do, the people who actually used the NEMT benefit and what their approval rating was. And so in each of those states, it was a slightly higher cost when they were using different models, and the approval rate was usually quite a bit lower as well. But we have one study currently that we're looking at, a couple other states that use a integrated modeling, and so we don't have those results back. But the states that use other types of modeling, that's what we found so far.
Can I just ask one follow-up? The report on the did you say hybrid model?
Sure. Yes, sir.
Okay. When do you think you'll have that data back?
Sometime at the end of this year, we'll have all that information back. We would be free to share that. Absolutely.
Okay. Thank you.
Thank you. Next on the list, Representative Fleming. You're recognized.
Thank you, Mr. Chair. Thank you all very much for meeting with me about a couple weeks ago, and we had a good discussion and trying to follow up on some of those questions I've asked. First of all, in your page on slide number 4, you mentioned a utilization rate of 18%, and we discussed that y'all looked at the whole base and did 80%, but also I don't know if that's truly accurate in terms of looking at the total eligible that could be used. So could you explain that a little more for me?
Sure. And so we started on our part. So we took the number of actual eligibles, which at first I think some data that you had all Medicaid members listed on it, who all Medicaid members aren't eligible for NEMT services. So we took the members that were on that QMB type coverage, and we took the members that were in that K-chip type coverage, removed them from the number of eligibles because they're not eligible for NEMT services. And then we sent that to the Kentucky Department for Transportation, and I'll let them explain how they looked at on their end.
Right. So we took those 1.3 million eligibles that Medicaid submitted to us. We ran those through the CAVIS system in the Transportation the Kentucky Automated Information Vehicle System, and that's what produced that 24% of that 1.3 did not produce a vehicle. And so if you consider that, and
Let me interrupt you. You said 24%. In that data that I looked at, that was accumulation of each region of 1, 2, 3%. And you add them all up to be 24%. That does not represent the accurate number, unless I'm misinterpreting what you're telling me.
no, this is totally different from that. When we took the eligible list into the vehicle registration system, 24% of those returned a vehicle. I'm not talking about utilization itself. I'm just talking about that number that Justin was talking about. 24% returned a vehicle. Now, we also went back and we looked at through each region for the last fiscal year in 25. We looked at each month, each broker, the unduplicated population that used the service, and it came out in FY 25, state fiscal year 25, about 61,000 members was the unduped population. Now, if you look at the ones who only had a vehicle, which out of the 1.3 million, this is going to get a little confusing, but out of the 1.3 million, there was 392,000 that basically did not have a vehicle. So when looking at the
And that's 24% you have in your slide?
that's the 24%, yes. And so when you look at that and you look at the undupes, if you take the 61,000 into that 392,000, it comes out to about a 29% utilization for those who we expect base eligibility that would be using the service. Now, again, with
And
that,
you're paying for everybody. I mean, you're paying for the whole population, but you only have, say, 20% being utilized.
correct. In the current capitated system, it looks at the cap payment, like the $5 a month or $6 a month, is paid on every eligible member to the broker because they have to be ready to transport them because they don't know who's going to call from day to day. However, whether structure is capitated or what, the cost of the service, out of the 174 million, we paid out for direct services 147 million of that. And so if that's direct services, then you put the admin that the broker is required to get to provide the call center in each region and to ensure transportation is in every county in Kentucky, then that's what uses those dollars. So whether it's a capitated payment, whether it's a service plus admin, which would come out to put the risk on the state, would be a whole lot higher payout. The capitated payment system, the cost is the cost of the service. The cost of doing the business, the cost of transporting is what it is, no matter what the payment structure is. So yes, when you look at it, it looks like the state's paying for members who aren't using it. But if it wasn't built on that structure, there would have to be another structure, either a double, triple, quadruple cap rate, or pay for direct services plus the admin on top of that. So, which would put the risk back on the state. Right now, the risk is on the broker, and we have some brokers that operated at a 96, 97 margin loss ratio, meaning they had 3% left over, and they're supposed to be at the 15% for admin. So it's risk on them. Some months they lose, some months they gain, and it comes out even. So it is true when you look at it.
Yeah. You gotta keep following up, Mr. Thank you. Staying on slide 4, 76% have vehicles with the asterisk, and 24% do not. And you have asterisk as a beneficiary of driver's license registered vehicle may still qualify. I assume that the car is in the house, but they don't have access to it, or they physically cannot use it, even though they might have a driver's license. They can do that. How do you track that? How do you know for sure what's going on with that information?
So when a member actually calls in for a trip, it goes through an eligibility verification process. And at that time, that's when we go through, first we determine, are they eligible? Are they going to a Medicaid covered service, a medically necessary covered service? Is it to the closest place that they can go to? This is part of the responsibility of the broker and the transportation cabinet. And then we run them, again, we run that member through the vehicle registration system as well as through driver's licensing. If the member does not have a license, they're not denied for a vehicle. If they have an active license, they've got an active vehicle, then we'll issue the denial based on a vehicle. And then once they get that official letter in the mail with appeal rights, they can call in and if they can try to meet one of the exceptions. Well, I medically can't drive my vehicle right now, I just had surgery, or maybe my vehicle is used by a spouse to go to work. So those things are taken into consideration to ensure that those who truly need the service do get the service. And so we verify and qualify that.
And those exemptions are listed in the administrative regulation for an EMT.
Okay. I can go so many different places. The broker responsibilities, is the MLR included in that? Or let me ask, do y'all have
Yeah.
loss ratio? What do you have, is that in your contract with the brokers?
I don't think the ratio itself is in the contract.
No, I don't think it is either,
Yeah.
and I think, and that really concerns me because I don't are being utilized in terms of promotion, making sure they're being satisfied, delivery, the wait times, all this stuff, and there's not a whole lot of reporting going on here, or even a lot of oversight that makes me feel comfortable when it comes to understanding taxpayers' money and doing this. Because what I can see also is that, and I may misinterpret, you budgeted about $180 million, and then you have cap rates of $175 million. So you have a $5 million difference. Now, I don't know if it's already been allocated, if it's sitting there, does it go back to general funds?
So
Could you answer that for me?
Sure, absolutely,
Thanks.
to the best of my ability. So that money that's paid, right? So that contract of 180 million is kind of a guesstimate of how much it's going to cost. We don't know how many members per month are going to be able to be eligible, and so that it's paid on a per member per month basis.
Right.
So that was the amount of money that we paid the transportation cabinet. That's the same amount of money we draw down from CMS. So there's no $5 million left over because we never drew that down from CMS.
Okay, so even though you budgeted so much money, you don't actually have it there. It's
That's correct.
there. It's just a budget. It's sort of I don't want to say a placeholder. Okay, I just want to clarify that because it looks like that's what's going on, which is a little concerning.
Sure. If it was a normal contract and not instead of a capitated rate, we would pay Kentucky Transportation Cabinet $180 million. And then that's what we would budget. Because it's a capitated rate, we never know exactly the amount that we're going to pay them, and that's completely due to the number of eligibles that we have per month for Medicaid.
Okay. All right.
And we only draw those funds down when they're paid. So if we don't pay them, we're not drawing the federal funds from that.
Okay.
Thank you.
Go ahead. That's fine.
I got a quick question, just and you may have mentioned it, but the FMAP, the federal match for the non-emergency medical transport, what is that exactly? What's that number?
I don't know exactly what that is. I can get that for you, though.
But it goes up and down. Sometimes it's 79% or.
Yeah, it can fluctuate, but I can get the exact numbers per fiscal year and send that to you.
Okay, thank you. Next we have Representative Duvall. You recognize?
Yes, thank you, Chair. Appreciate that. So regarding the riders' surveys, you said 97% satisfaction. Who looks at these? Who views these?
Well, we do for the Department for Medicaid Services. That's part of our oversight for our contractor. We look at all the surveys. We go as far to contact different individuals that participate in the program. We have a survey out now that bypassed our contractor that went straight to the riders to kind of get our own survey. But the Transportation Cabinet sends out the surveys, collects those, and then they report those to us on a quarterly basis, I believe, or it's in their annual report as well.
All right, very good. Yeah, I've just had personal experience in my clinic with patients waiting. We're finished with them. We try to contact someone come pick them up, that they're finished, and then hours, and I do mean literally hours later, the patient is still sitting in the waiting room. So once again, it may have been just a skewed result here, but I find 97% a pretty high number. But once again, I would be interested in more accountability in terms of those surveys, maybe a little bit more transparency. That'd be my opinion. Thank you.
Yeah, I did want to note too that the Kentucky Department for Medicaid Services contacts any and all and investigates any and all complaints that we receive outside of the Kentucky Transportation Cabinet. In addition to that, what we found a lot, probably 90%, 95% of the cases that come in are Medicare Advantage plans. So they're Medicare plans, and the Medicare Advantage plan calls itself NEMT as well. So it's NEMT, Medicare, NEMT, Medicaid. And so 90 to 95% of the things we investigate are Medicare Advantage rides that we have no oversight over. And then a lot of the times we get complaints, such as one of the complaints that we actually heard in a testimony here was a complaint of a woman that had a child that was not able to get a ride because she had her child with her. The ride service, if they call and say, I have this child with me, can I ride with my child? They will allow that ride. But the lady showed up with a 6-week-old baby in her arms with no safety seat, with no child seat. And so the driver, not wanting to get a child endangerment charge, said, I can't transport you without the correct car seat. And so, we don't have Medicaid funds to buy car seats. That's not a medically necessary item that we can pay for or provide. So she was denied services until she had the right car seat. So we find those type of things as well all the time. Anytime that there's a issue where a member's not being picked up or they're having to wait hours, we would love to be able to hear about that so we can hold our contractor responsible. And I know the Transportation Cabinet would love to hear about that so they can hold their contractors responsible.
One more, Senator Berg. Recognize.
Thank you, sir. What do you consider an acceptable waiting time for a patient? What is adequate?
So once the call is made for a will call or return pickup, the provider has usually 1 hour to return to pick up the member, because those trips are some trips are scheduled for an exact pickup, but the majority, because with traffic and other schedule, because it's a coordinated system, usually it's within 1 hour that they are required to be back to pick the member up. And if they can't, then they should be scheduling that trip with another dispatcher. It also depends upon the subcontractor notifying the broker that, hey, I'm stuck in traffic, or hey, I've got a vehicle breakdown, or I'm not going to be able to, so they can immediately turn around that trip to another provider. But 1 hour is the standard.
We got one quick follow-up with
Thank you, Mr. Chairman. Have y'all, either one of you, the transportation or the cabinet, have y'all done any type of full audit on the services from a managerial point of view as well as a financial point of view?
Each broker is required to submit an independent audit to us.
That's not my question.
That's not your question.
I want to, have you done a full-blown audit?
We do twice a year. We do an on-site assessment.
Okay.
And we do, in the spring, we do what's called a desk review, to where we'll request certain documents, items, look at financials. But usually in the fall and spring. Right now we're in the what we call the fall assessment on-site visit. We go on-site physically. We inspect vehicles. We sit down with the broker. We look at their systems, operations. But each month the broker reports 10 different reports to us on the call center. They report their complaints. They report, of course, their trips, miles, and dollars to us. There's a survey that they're required to do to providers. They survey medical facilities every month to make sure that the provider, that the transportation company arrived on time, that there was no issues with the service itself. That's submitted to us. So there's a lot of checks and balances each month, as well as our yearly.
And do you have benchmarks, or do you have criteria, measurements that you go through that they should meet? And then if they do fall short or they do exceed it, is there any type of compensation or recognition? And does it reflect that in the contract?
there's no compensation or recognition for doing good. There's anything like that. There are fines and penalties in place in the contract if they do bad that we can follow up on, as well as each year before, or not each year, but when the contract is renewed, we have to fill out a performance evaluation for each broker that goes in the system, so that will affect the next bid coming up. If there's something in there that they were lacking in payments or in customers in the services provided, if there were a lot of complaints, that's all documented through finance that comes up at time of bid as well. So.
Okay, thank you, gentlemen. Thank you, lady. Appreciate your comments.
Thank you.
All right, thank you, gentlemen, for coming. I'm sorry. Thank you all for coming today, and ladies, spending your time and kind of getting behind the scenes. Look at this. We appreciate that, and I think the information was timely, and it's good. As we're developing this budget, and we're kind of looking at every line item we can to make sure that we're providing the services we can. So we appreciate you coming today.
Thank you.
All right, the next item on the agenda today is an update from the reorganization of the Child Support Enforcement Program from CHFS to the Office of the Attorney General. I think the Attorney General office had several, so we're going to do the cabinet first, if you don't mind. Mr. Duke, I think, is representing us.
sir.
All right. If you wouldn't mind, we'll go ahead and swear you in. If you swear to or affirm to tell the truth and the whole truth and nothing but the truth.
Yes, sir.
All right, thank you. Now, would you identify yourself for the record and go ahead with your presentation?
Absolutely. Hi, my name is Wesley Duke, and I'm the General Counsel of the Cabinet for Health and Family Services. And I don't have a PowerPoint or anything here today. I really wanted to be here to answer any questions that the committee had. I can say that it is our position that the child support transition from CHFS to the OAG pursuant to Senate Bill 48 from 23 session, I believe. I can't say it's been a while. Went in our, it was not without its bumps along the way, but it is complete, and I think it was a fairly smooth transition. We have a couple of things that are still kind of hanging out in regard to technical issues, and I'm sure you'll hear about this from OAG. For them to continue to do business, they have had to remain on some of our systems and use our systems, and that's fine, and we've accommodated that, and to, like I said, for them to do their daily business. And we're still talking through what that looks like and having those conversations. And like I said, it was a fairly smooth transition. I know that personnel matters went well. We completed all the county attorney contracts and got those all squared away. And it's like I said, we're at a point now where we're just kind of hammering out some of the remaining details. And I'm here to answer any questions from a cabinet perspective, but Senate Bill 48 was a large piece of legislation, and the child support transition was the final step in that. And we were, like I said, we finished it up, and I think it went as well as it could have. So, like I said, I'm here to answer any questions from that.
Do we have any questions from the members for Mr. Duke? Senator Berg, you're recognized.
Thank you. Do we know if collections have improved since the transition?
I'm not aware of any hard numbers on that. I mean, we've got we've only had a few months as far as that transition goes. But as far as what we're looking at number wise, I think the program staff that's here could probably answer that. Like I said, I don't know what as far as where we are today, I don't have any numbers on that.
All right. Thank you. Thank you.
Anyone else? All right, hearing nothing. Mr. Duke, if you wouldn't mind just kind of hanging around, and if we have some follow-up questions, we might do that, or rebuttal, or whatever.
Absolutely. I'm here to answer whatever the committee needs. So
okay, thank you very much. All right, from the Attorney General's office, we have Will Schroeder, General Counsel for the AG, Amy Burke, and Stacy Woodrum, also with the Attorney General's office to discuss the transition on their side today. If you all wouldn't mind raising your right hand, do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you all. Go ahead and say your name into the mic. Identify yourself for the record. Thank you, and go ahead.
Good morning, members. Will Schroeder, Senior Counsel for the Attorney General's Office.
Good morning, members. My name is Amy Burke. I am the Chief of the Department of Child Support Services under the Office of the Attorney General.
And good morning. I'm Stacy Woodrum. I'm the Executive Director of Office of Management and Budget with the Attorney General's Office.
You guys can go ahead whenever you're ready.
Co-Chair Richardson and Co-Chair Williams and all members of the committee, thank you for the opportunity to update you on the transition of the Commonwealth's Child Support Program from the Cabinet for Health and Family Services to the Office of the Attorney General. On behalf of Attorney General Coleman and my entire office and staff, I'd like to begin my presentation by saying thank you. We're grateful for the ongoing partnership from the General Assembly to take on what Attorney General Coleman refers to as a no-fail mission. Our department is responsible for operating this complex federal and state program with the goal of delivering support to families and the children that rely upon it. In 2024, Kentucky's child support program served approximately 210,000 children in this Commonwealth, collected $319 million, and Senator Berg, I will say that usually those collection numbers we look at those at a year-end rate as opposed to quarterly or otherwise because they fluctuate so much. And a lot of times, sometimes the statistics lag behind a little bit. But 2024, $319 million. As of this summer, nearly 140 employees, state and contractors serve the Commonwealth in this Department of Child Support Services, and more than 700 public servants in county attorney offices, which are located in almost each of the counties here in Kentucky, make this program work every day. I'm proud to report that the formal transition took place on July 1st of this year, and really no one even noticed. We successfully moved the program from the Cabinet into the Office of Attorney General with minimal disruption to the people that rely upon it, which was the most important goal. A lot of the credit for that day one success goes to the team assembled by the Attorney General, including, as you've met, our Director of Office Management and Budget, Stacy Woodrum, my Deputy Chief within the Department of Child Support, Robin Shire, the Child Support General Counsel, Stacy Talby, and our Executive Advisor, Rob Trimble, and many, many others. In these first few months of taking over the program, we have executed over 100 county attorney contracts. Those are our on-the-ground partners. We are working toward an essential replatforming of the CASES system, that's the Kentucky Automated Support Enforcement System, as a precursor to the incremental modernization of that statewide program and technology, which is woefully outdated and obsolete. And Attorney General Coleman established the first ever Child Support Advisory Council to draw on the experience and expertise of local leaders and people across Kentucky in both counties that are big and those that are small. We're fully operational today, tackling the obstacles as they come and providing the support that can make all the difference in the lives of young Kentuckians. Despite all that positive progress, we do face serious challenges that threaten the long-term health of Kentucky's 4D program. As we prepared for the transition from the Cabinet, we identified major budgetary shortfalls in the child support program, and they total over $13 million. The shortfalls were created in two ways. First, lack of budgetary planning meant that the Cabinet usually and historically ran out of money for the child support program by the end of the third fiscal quarter, meaning in that fourth fiscal quarter, when it comes time to close things out, they would roll into the funding that was then in place for the first quarter of the next fiscal year. So more than $4 million of unpaid obligations were passed on to the Office of Attorney General in this transition. Second, and perhaps more concerning, the Cabinet misused federal incentive dollars, which amounted to approximately $7 million a year in full federal funding. There's no match to that. It's fully federal. Even after learning that this practice constituted a violation of federal law and rule, the Cabinet continued to misappropriate funds. Since the first month of this administration in January 2024, our team has worked to address those issues that were at our attention. We're here to update this committee and the General Assembly and ask for your continued partnership in what we seek to accomplish. The Attorney General's biennial budget request contained our priorities to address these structural problems, It is a critical step to turning the page on the problems of the past and promoting the health of this program for years to come. We're committed to delivering on the mission that you gave us in Senate Bill 48. We're not going to kick this can down the road any further. We're simply asking for continued partnership and help with making this program work, and of course making it work on behalf of the families and children here in Kentucky. Even with a full view of all the challenges that have been inherited, our team has already taken constructive steps to right-size the child support program, streamline operations. We've tightened our budgets. We're in the process of trimming third-party contracts that fed the bureaucracy but did little to actually support the mission. And we're discussing new and constructive ways to use federal incentive dollars appropriately to build a better child support program that I hope all of you and your constituents can be proud of. In closing, we're only in the 4th month of this new program. We're very proud, I'm very proud of what's been accomplished so far. And with your help, I think that we continue to improve upon this program for all Kentuckians. Thank you again for the opportunity to be here today before all of you, and we welcome any questions that you may have.
All right, I just had a couple of questions real quick. You talked about renewing or updating the software associated with tracking. Tell me about that and what it looks like. Is it homegrown? Is it built in-house? Tell me what about that, please.
It is homegrown in the sense of the CASES system, the Kentucky Automated Support Enforcement System, is the system by which all child support is handled. So all the caseworkers, whether state or in those local offices, get a work list and work off of cases. All the money comes through and distributes. CASES was built, I believe, in the late 80s, early 90s. I was trained on it in 1998 as a brand new prosecutor in child support services in Kenton County. It is written in what's called COBOL code, which is an obsolete code. So those that we have on our staff, our contractors that work on it, are all in their 70s, and God bless, I hope they stick with us so that it can continue to operate.
Yeah.
So the first part of that and what had begun under the Cabinet administration was an RFP to re-platform or to bring that into .NET. And then from there, once it is re-platformed, which does not modernize it in any way, does not change the way it looks. If those of you that remember the movie War Games, it kind of does look like War Games. It's a very antiquated old system. It will not modernize any of that, but because it will be in a code that is widely programmed with today, we can then look at incremental modernization to do some things that help us collect child support and work smarter and not harder. Cases, I believe in 2012, there was maybe a movement to replace it, but what happened instead was a suite of programs were built around it to support it, like a business intelligence, maybe some, forget what it's called, sorry, I'm not a tech person, but an online database of forms and different things, and just where we hold all the files and everything was built into it and things like that. Mr. Duke kind of referred to it, but that system of those suite of other processes like our policy and procedure manual and so forth, some of that will be obsolete by next year. And so we kind of inherited all of that, all of which, you know, is obsolete. So that's kind of what we're looking at there. And I believe the General Assembly did in 2020 or 2018, I can't remember, when the capital funding was put in place to make that modernization of the CASES program.
Did you say in 2020, you think?
I think it,
And we're in 25 now? Is that a normal time frame, I'm assuming? Probably the way
I don't know, sir.
Unfortunately, yeah.
With some of the technical projects, you know, going out for RFP and the requirements of that, it does take a lot longer than other contractual.
And because it's a state federal program, it's not just within the state's hands to decide. We then have to go to our federal partners and have everything approved at that level.
Inspect and all that
Yes, sir.
stuff. I got you.
Sir.
All right, does anyone have any questions? Oh, I got one question here. Representative Johnson, you have recognized.
Thank you, and I probably have two questions, Mr. Chairman, if that's all right. Just to refresh our memory, can you tell us just very briefly, the broad categories of child support that falls under your jurisdiction when we move this over to you guys. What did you inherit?
Sure. So the broad categories are mostly judicial, which is why we have the over 700 local officials, county attorneys, are establishment of paternity, where children are born out of wedlock, establishment of support orders, medical support orders, so there might not be an actual child support order, but there could be an order to have medical insurance on behalf of the child if available to you. Collection of arrears, whether that be administrative collection, like a lien or something to that effect, or state tax offset or federal tax offset where we take taxes. It is also arrearage collection, so those things that are accumulated and collecting upon those, maybe by order or so forth. And there's, those are kind of the suite of things. Now within that, there can be a lot of little specialities. So we deal with other state orders. So we have a Uniform Interstate Family Support Act, which is kind of a niche area of child support whereby we help other states obtain orders. If someone lives in Kentucky, there could be, say, you know, you have an employer like Kentucky and we want to get health insurance for your child, we might have to do a qualified domestic relations action paperwork to get the child on the paper. So a lot of civil work goes into it, some criminal work as far as enforcement, but pretty much the whole thing is aimed at establishing paternity, getting paternity established, setting a support or a medical support order, and then collecting upon that order and having that state unit set up so the money flows in and the money flows out. And those are sort of the goals of the program.
Go ahead. So with respect to establishing paternity and the process involved there, I don't want to try to discuss this during committee, but could we talk offline about
Absolutely.
the process that's involved with establishing paternity, particularly with respect to adoption processes when you're trying to establish paternity and that whole process? I'm kind of curious about that. So could we talk about that offline if you would, please?
Absolutely. And if any other member of the committee has any interest in all the facets of child support, we're always able to come over. I can talk your ears off about child support.
And just a comment, COBOL?
COBOL, yes, sir.
Really?
Yeah, my first question when I took the position from General Coleman was, what program are they using now? And they said cases. I said, what version of cases? They said cases. And I went, oh dear.
Exactly.
Cases
Thank you, Mr.
AD.
Chairman. Appreciate it.
Do we have any more questions before we move on? Quickly, Senator Burr, if you don't mind, it's 5 o'clock somewhere almost. If you look at the clock
so
back
much time
there,
to have a drink. Okay. Just real quickly, because it seems to me the additional ask was 13 million.
So not completely, but yes. So Senator Berg, that's what our shortfall is. But when we asked to fill that $7 million hole, so whatever appropriation was given, we have to fill $7 million per fiscal year. We're asking now to do that through the proper split of state funds, which are matched 66% by federal funds. So our ask is not sort of as big as that because we're using the proper method, which is that the state does 34%, our federal partners match that at 66%, whereas they were taking those incentive funds incorrectly, which are all federal dollars, and just sort of when they expended all the amount in the state fiscal year, all the money, they just sort of brought that in and used it, which was a...
Okay, so I was trying to figure out that was the 7 million that was being used inappropriately, the 4 million in what I would consider sort of rolling
over.
And then I was trying to figure out where the other 2 came from. But okay, we don't have time. Just afterwards, explain it to me.
I can, and if you look at the 2024-2026 budget that was done by the cabinet, on the very front of it, they say, as a result of changes to the federal child support funding stemming from the Deficit Reduction Act of 2005, federal incentives were excluded from the use of state match purposes after October 1st, 2007. For Kentucky, which averages about $7 million a year in incentives, this poses a potential loss of approximately $14 million in federal funding each fiscal year unless state funds are made available. So while they knew that, they didn't put that into our budget, which I'm operating with now. So now I have come to you as partners and or our office has, excuse me, not me personally, and made an additional budget request. But now it would be that split of state and federal dollars. So while there is a $14 million hole over the biennium, it's not as big an ask because the feds will match anything the state appropriates with 66%. But I'd be happy to explain that further. You're welcome.
All right. If there's nothing else, we appreciate you all coming. Mr. Duke, do you want a very small amount of time for anything, or?
I would just like to clarify that the case's funding was in the. I'm sorry.
Yes, please. Thank you all for coming. You can be excused from there.
No, I would like to just clarify that
Yeah.
the case's funding for the capital project was in the 22-24 budget.
Okay.
So, which was, and so just to, like I said, I know that was a issue, so I just want to clear that
Yeah.
up. My budget director,
Okay.
just text me, so as long as y'all know that.
All right. Thank you so much.
Thank you.
All right. Thank you all for your presentation today. And we're down to the last item today on the list. Or next to the last. Oh, I'm sorry. I'm really behind here. So next item on agenda is an update on the funding provided for the Pediatric Cancer Research Trust Fund. We have Elizabeth Turner, Heather Jones, Dr. Eric Durbin, and Lauren Hayes. We're missing somebody, I guess. Provide that information. So if you members would mind to raise your right hand. Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth? Thank you. If you would, when you identify yourself with your name for the record, then you can present. You can go on with your presentation. Now we're running a little bit behind, so if you would, we'll get through it pretty quickly if you wouldn't mind. Thank you. Go ahead. Push the green button until it's lit up.
Heather Jones,
Gotcha.
board member.
Good morning. I'm Eric Durbin, director of the Kentucky Cancer Registry and board member.
Good morning. Lauren Hayes, pediatric psychologist and assistant professor at the University of Louisville Norton Children's.
Thank you. Go ahead.
And Elizabeth Turner won't be with us today. She works for UPS and was called in to work. So our thoughts and prayers for her and her colleagues. So we will be taking on her portion of the presentation.
Okay.
How do I get that on there? How do I do not to get that on there? Okay, thank you. I just click it. Okay. Not used to presenting. Thank you for having us today. I'd like to thank the committee, Representative Williams for fitting us in, and Representative Heverin for hooking us up with the meeting. And I'd also like to recognize our program directors, Janet Luttrell and Carol Cecil. They're in the audience. And my name is Heather Jones again, and I'm going to start our presentation. The Kentucky Pediatric Cancer Research Trust Fund, we were established in 2015 by Senate Bill 82 and sponsored by Senator Max Wise, the father of a neuroblastoma survivor. I'm most proud that this fund is the product of a collaborative grassroots advocacy work of many Kentuckians, families, and parents and grandparents of childhood cancer patients. Kentucky serves as a national model for other states, replicating our success. As you see here in the graphic, the Kentucky Pediatric Cancer Research Trust Fund is an independent board administered by the Kentucky Cabinet for Health and Family Services. We meet approximately 4 times yearly to review grant applications and progress reports. We have 63 research projects funded, including psychosocial projects, and we have 7 family support projects funded. So you can see in the graphic, we've incrementally been increasing our ask and appropriately spending those funds, and we'll work on our ROI here shortly.
Just a quick briefing. You do not have to hold that button, so you don't have to be
Don't have-
doing
okay,
that.
sorry.
There you go.
Okay.
Thank you. Go ahead.
Dr. Durbin will take it from here.
Chairman Williams and members of the committee, really appreciate the opportunity to speak to you today. So I'm going to share some of the basic facts about childhood cancer in Kentucky. And while these facts are troubling to hear about, there's actually some encouraging news here. So I would like to draw your attention to the trend line shown in the graphic here. And this is a trend of invasive cancer incidence rates for pediatric cancer, so between the ages of 0 and 19. And we had experienced a steady increase in those incidence rates up until the year 2017, and since then we've actually seen a slight decrease in the incidence rate. So that's we're moving in the right direction. So that's somewhat encouraging news. But in spite of that, considering this time period between 2013 and 2022, over 2,775 children and adolescents were diagnosed with cancer in Kentucky. And those figures actually include invasive and non-invasive cancers as well. But that means about every other day, a child in a family in Kentucky learn of a new cancer diagnosis in their family. In Kentucky, our children have the 5th highest cancer incidence rates compared to all other states in the U.S. The pediatric cancer rates are higher in Kentucky than in the United States as a whole in 10 out of 11 major cancer types. So when we break it down and look at different types of cancer, we are quite high in either Appalachia, Kentucky, or Kentucky as a whole compared to others. And I think, Heather, I had one other fact I wanted to share in that previous slide. And so one of the more troubling cancers in Kentucky is actually in brain tumors. And so brain tumors have become the leading cause of death related to disease in children, and it's recently overtaken leukemia as the most frequently occurring type of cancer diagnosed in kids. And in Kentucky, we're also 5th in the nation with the 5th highest rate of brain tumors in the United States. So as a direct result of funding from the legislature for the trust fund, this is an example of a study where we're taking a careful look at where those brain tumors occur in the state of Kentucky, and we were surprised to find a cluster that occurred in the north central region of the state of Kentucky, which is depicted here in the circle area there. That covers approximately around 40 counties in Kentucky. Not exactly what we expected. We might have expected to see higher rates in the eastern Appalachian region of the state, where we tend to have the highest rates of all types of cancer. So this is a very interesting finding, and that's led us then to look at additional environmental exposures in the context of inherited risk factors of what might be behind this. And so one area that we're looking at currently is in pesticide exposure, and we've conducted a survey amongst survivors to learn that a large number of kids were exposed to pesticides either in the home or in agricultural areas adjacent to the home. And we're also looking at exposure to aflatoxin. Curiously, we have identified the signature of aflatoxin in certain brain tumors in Kentucky, and this is a somewhat novel finding, and thanks to the trust fund, we're going to explore that further.
Hi, I'm going to share a little bit about 2 particular research studies that the board has supported in this funding cycle. The first, Project Inherited Cancer Risk, is led by Dr. John D'Orazio at the University of Kentucky and Dr. Michael Ferguson at the University of Louisville Norton Children's. This is a statewide initiative to screen for genetically inherited cancer risk. This study involves screening for more than 120 cancer-relevant genes and conducting cascade testing for family members to allow for cancer preventative actions and early detection of tumors. This study also supports a pediatric tumor board, which increases statewide scientific collaboration and ultimately leads to better clinical care for our kiddos. To date, 260 patients have been tested through this initiative, and 8% have resulted in positive or undesired sequencing results. And through this screening, those Kentucky patients and families have received that essential access to early detection and cancer preventative treatment. This second study is near and dear to my heart. It is a study that I'm the principal investigator of, trauma-informed procedural pain intervention. This is another statewide collaboration. My collaborator, Dr. Megan Marsack, is at the University of Kentucky. We're pediatric psychologists by training. We know that poorly managed pain during pediatric cancer treatment can lead to a lot of adverse health outcomes, and unfortunately, pain management is overlooked. We're trying to keep kiddos alive. Our oncology partners are trying to keep them alive, so it's often overlooked, but can have some grave consequences into survivorship. So we assembled a group of experts, including pediatric psychologists, pediatric oncologists, to develop an evidence-based psychological intervention. There's a lot of research to support pain management, psychological interventions for pediatric pain management. Unfortunately, it's hard to translate some of that research into clinical practice. So that was our mission, and we developed a study or an intervention that is tailored to pediatric cancer patients. We're currently in the process of doing a multi-site clinical trial to test how effective this is. We've already established this as a feasible and acceptable intervention, so families like it. It is possible to do the intervention in a real-life clinical setting. We have 30 patients enrolled. The study has already helped to broaden the knowledge base internationally, nationally, on how to translate pediatric pain research into clinical practice, which again is much harder said than done. And we're hoping that the results of this clinical trial will really help us be leaders in establishing pediatric pain management practices across the nation. So those are two studies that we wanted to highlight in addition to Dr. Durbin's study.
Our return on investment. So far, we have federal grants totaling $4 million awarded to Kentucky. We have the first good manufacturing practices pharmaceutical facility at Norton Children's, where clinical grade novel CAR T immunotherapy is produced. We have multi-centered national medulloblastoma phase 1 trial. I'm most proud of this, a top talent fund to attract leading childhood cancer researchers and providers to our state universities and hospitals. Prioritization of psychosocial research projects to treat the whole family, and monetization included in grant award contracts. We've funded projects resulted in 111 presentations and publications, 63 presentations, 30 publications, and 18 research publications. So here is our ask. Cancer remains the leading cause of death by disease in children. Kentucky children are diagnosed at a disproportionately higher rate than other states, and prioritization of childhood cancer research warrants continued expansion. We're requesting an increase to $15 million over the next 2 years. That's $7.5 million each year to build on current project momentum, expand transformative research, and support new initiatives. Research takes time, and it's the only way for safer treatments and better outcomes for our children and families. More than 47 applications totaling $21 million have been received for the next budget cycle. And we just want to thank you for your thoughtful consideration in supporting the Kentucky Pediatric Cancer Research Trust Fund. We are a national leader in state-supported support of childhood cancer research. And I also just want to personally thank you as a childhood cancer survivor, mother, and advocate. This is very important that we take care of our children and families here in Kentucky, and I'm just really proud of what we're doing here. And we'll take questions.
Thank you all so much. We have a couple quick questions. We want to be respectful of our next partners, if you don't mind. Senator Berg.
Thank you, sir, and thank you guys for the work you're doing. This is an awesome presentation. My question, actually, has to do with data. I'm seeing data from the Cancer Registry being presented to to us routinely that is out of date. It is, we got presentations about colon carcinoma with data going back to 2021, 22 that I objected to. The data you all showed us today is 1995 to 2019 and 2022. That was the data from our Cancer Registry. Is there a problem? Can we not get more current data?
Senator Berg, that is an excellent question. And this is it's related to the way the population-based cancer surveillance is conducted across the United States. We all follow a uniform set of guidelines and procedures, and it takes about 23 months to complete all the population-based data for every individual in every case of cancer in Kentucky. And this is essentially the national standard. This is the expectation. So as a matter of fact, we just completed our 2023 diagnosis year. Literally on Monday, we completed our finalized data that's been, and I can explain the reasons behind that. Data comes in concurrently. So we already have quite a bit of data from 2025. But when you have to sort through death certificates and literally hundreds of different sources to get every last case of cancer, and to truly finalize that to be truly representative of every individual in the state, it takes a lot of time. But we recognize that that's unsatisfactory for you to be looking at data that appears to be 2 or 3 years perhaps out of date. It's actually 23 months is really the amount of time that it takes. So I have the privilege of now serving as the president of the North American Association of Central Cancer Registries. And my mission as president of NACER, and this is the organization that establishes the standards that all cancer registries in the United States and Canada, hospitals and state registries utilize. And my mission is to figure out a way that we can produce reliable, more current information. So one of my ideals around this, and it's not just my ideal, it's myself and others, is to pursue it a little differently, where there's information that's readily available early on, we take advantage of that and compile those statistics. And one example would be pathology reports. About 95% of all cancer cases are histologically confirmed by a pathologist. So if we could collect pathology reports and at least produce initial incidence rates based on pathology alone, while it may not be perfect, it would be informative, and those data would appear to be more timely. And so we are working on that. And I will say that Kentucky is actually leading the nation in our ability to collect pathology reports. We have some challenges here and there from some facilities, but we've made a lot of progress there. But I understand your concern, and we're taking measures on a national basis to address that.
Thank you. I'm glad I'm not the only one that finds this to be a problem. Thank you.
Thank you, Senator. Representative Wildner.
Thank you, Mr. Chairman. Thank you for a really wonderful presentation and for the work that you're doing. Dr. Hayes, I wanted to particularly thank you. I think the work of health psychology is not very well understood in this state.
Yes.
And Kentucky has been historically behind the 8 ball, behind what other states are doing in terms of integrated care. I think this work is so incredibly important.
Thank you.
I think this true integrated model is such an important and valuable investment. So thank you for the work, and thank you for also raising awareness that it's not all on the medical side, that it really, when it's multidisciplinary, that's when we get the best results. And so thank you for championing that.
Thank you so much. I appreciate your appreciation.
Thank you. Next is Representative Hebron.
Thank you, Chairman. I just want to thank Heather for all her work. She is such a tireless advocate. I'm very honored to have her as my constituent. And just to take, I can't imagine the pain it feels to be a parent with a child that has cancer. And so thank you for taking your pain and your hurt and turning that into advocacy and loving other people. So what a treasure for you all to be here today. Thank you for sharing the work that you're doing. It really does make a difference.
Thank you. Thank you for your support, and we always appreciate the support and the funds that you give us to do all these wonderful things, that Kentucky leading the way.
Thank you all for the work that you do, and thank you for coming here and taking time out of your day and for the presentation today.
Thank you.
Thank you.
Thank you.
Thank you.
All right. Next on the last item on the agenda is an update on funding for hospice care services from David Cook, Tawanda Osley. I hope I didn't mess that up. Representing Hospice Health. If you would please have a seat, and if you'd raise your right hand quickly. Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth? I do. Thank you. If you would now push the button to make the green light come on, and then introduce yourself for the record and go ahead.
David Cook, President. Oh, it looked like it was on, but it was not. David Cook, President and CEO of Hospice Health.
Tawanda Owsley, Chief Development Officer at Hospice Health.
And we have a brief presentation that we will make especially brief.
Thank you. We got hopefully about 10 minutes, so we have
Okay.
a little time if somebody has anything.
All right, thank you all. We are pleased to have the opportunity, and thank you for your time today to present to the committee. I believe in our 47 years, this is the first time we have made a specific request for Hospice Health. And to give you a little background, Hospice Health was founded in 1978 by community members. Those were individuals who saw a need to provide a better way for patients to live at the end of life and to receive compassionate care and support. Our organization serves 41 counties. We provide volunteer services, specially trained professionals, symptom control, medication management, personal care, counseling, spiritual services to the patient and their families in those counties. We recently were ranked 4th nationally in an article among large hospice programs as far as quality of care, that being based primarily on satisfaction surveys and reports on Glassdoor, Yelp, and others. So we were very pleased to receive that recognition. As you see in front of you, these are the counties. Many of these counties fall within your service areas, and these are the counties that Hospice supports for patients and families. Our request today is around establishing a new hospice care center. This is a visual of what the care center will look like, and it is located in Louisville, next to the Jewish Community Center, there across from Bowman Field. It's back, Ephraim McDowell is the actual address, is where the facility will be located. It is next to our grief counseling center that we built and established just recently, with a walking path that will be between the two facilities to be able to support patients or family members along their grief journey, whether that's participatory or post the loss of a loved one. This is a very small diagram of what the inside of the building will look like. The important pieces here is this is a nearly 30,000 square foot facility where we will have 21 beds, lots of space for families to gather, discuss, talk about their family needs, services. We'll also be providing food services. This will allow us for the first time to be able to take a patient and allow them in the bed to be rolled to the end of that facility and actually be outside in outside air and to feel the sun on their face and to spend time with their family outdoors. So we're really thrilled to be moving forward with this facility and these 21 beds. Tawanda?
So we've been actively fundraising for this campaign for a few years now, and we've been pretty successful, and we're really proud of the efforts that our community has supported this project. So today, it's a $20 million project, and we've raised nearly $10 million toward our efforts. Most of these dollars have come from grateful families and individuals that have experienced our service and are satisfied with that service and grateful, and they're showing their gratitude through donations. So a large portion of that has come from individuals, some from family foundations, and some from private philanthropy. So we're really excited about the efforts that we have had so far, and we are respectfully coming before the committee to submit a request for $5 million to help us toward that bold goal of a $20 million project. Some notable funders of this project are some community leaders in the Louisville area, predominantly and throughout our state, Norton Healthcare being a strong supporter of this project. We currently have our inpatient care facility located in their downtown Norton Hospital facility, so we will be relocating to a brand new facility, and they've been long-term partners with us, and we've been very satisfied with our relationship. We just need a more modern space and a more upgraded space and a more accessible space for most of the community. entities. Republic Bank, the Harshell family, which is a known Louisville family, the Legacy Foundation of Kentuckiana, and private donors and foundations have been advocates and supporters of this project.
So community need and benefit. So our current facility is inadequate for the needs of our patients and families. Even though it's on the penthouse of the old Methodist Hospital in downtown Louisville, problems come with being on the penthouse with roof leaks. And Norton does a great job of trying to support us. But the rooms, there's one shower on the entire floor for all patients and families. And there are many other things. I'd be happy to speak to you about some of the other issues that we deal with. I like to think that we have provided for a number of years excellent care in a less than excellent space, and it's time for that to change. Where we can honor families with a great space so they can be focused on the last moments with their family. This is critical services. Again, these are for individuals who are facing either a situation where their care, pain, symptom management is out of control, and we need 24/7 management to be able to get them comfortable and to manage that, whether they're going home or whether they're going to spend their last days in our facility, which often is the case. This also serves as an opportunity for individuals who are caregiving, who are just exhausted and need a break. So this is also a place where we will provide respite services for family members. Kentucky and federal regulations require that we provide this in a home-like setting. That is our goal here, is to make this a comfortable place for people to be, to feel as if they're at home and to feel supported. We have looked at the number of individuals that we serve that are Kentucky Medicaid as their primary pay source, and with an average length of stay of between 15 and 30 days. Statistically, some of the surveys that are out there and research would estimate that at $3.215 million in savings that hospice brings to Medicaid for that number of individuals. And so we're thrilled to be able to continue to provide quality care at lower cost by avoiding some of those unnecessary hospitalizations and supporting people in a more comfortable environment.
Thank you, Mr. Cook. I think we have one quick question at the end. Representative Wilner, you recognize.
Thank you, Mr. Chairman. Thank you for a wonderful presentation. You don't know this, but I'm a huge ambassador for hospice.
Thank you.
My mother we all used your services in my mother's final months. It meant the world to us. Thank you so much. It was very important to our family and to my mother that she wanted to remain at home. And while I have seen with my own eyes, I understand the need for this facility. Will this in any way have an impact on the support that you're providing to families who choose to remain at home?
Our goal is always to be able to provide support where a patient wants to be. And I think from our roots, that has been to try to allow people to be at home where they're most comfortable. Unfortunately, sometimes because of symptom management issues, it's not possible to keep them comfortable in the home, and we need to move them to a setting. And not everyone is in a setting at home that is actually going to be able to meet their needs. So we do see that this will support those who can't get the care that they deserve in a home setting.
And then the ability to provide respite care. So while you're at home, to be able to leave and take a trip or take a vacation, you would be able to bring your mother or your loved one to our facility.
Thank you. I just wanted to make sure that this was in addition to and not instead of. Thank you so much.
Yes. Thank you.
Thank you so much for your presentation today, and we thank you for the work that you do, and appreciate you taking time out of your day and present.
Thank you very much.
So with that being said, before we adjourn, members make note, this is our last meeting for the 2025 interim session, and I would like to thank everybody for your participation in this committee, and I think we've dug some good topics out, and we'll probably continue to do them in the session. Thank you all, and do I have a motion to adjourn? Everyone say aye. Thank you. We adjourn.